Macy? Someone? A lot of no's. Okay. Matrix-associated autologous chondrocyte implant. Does that clarify at all? Not really?
Not
okay.
exactly.
All right, I'll keep trying. The Macy implant is an implant of the patient's own cells, which is utilized to repair cartilage in the patient's knee. So cartilage, as we know, does not actually have very little ability, I should say, to actually repair itself, right? So if it's damaged, what we know is that the defect, if identified, is going to continue to progress over time. So where that leads down the road, if there's not some level of intervention at some point, could be osteoarthritis, it could ultimately end up in a partial or total joint replacement. So this little membrane is an opportunity to intervene and repair the defect with the patient's own cells. Just a quick background. This is not some like fly-by-night science. This was actually first started in 1994, so over 30 years of science and data behind this. What changed over that period was just, one, most importantly, the delivery method, how we get it from the patient to the lab, back to the patient as neat and cleanly as possible. And there's been a lot of studies along the way comparing it to other procedures that can be done, kind of supporting the evidence that this can be a really good option for some patients. But again, we know with injuries, cartilage defects, there's very little ability for that to be repaired by the body itself. So that means that the injury is going to keep progressing. That can be pain, swelling, discomfort, locking of the joint. It can really present itself in a lot of ways for how that impacts the patient depending on where it is, but the long-term outcomes are typically much greater issues. Again, we have over 30 years of data behind the science and the concept. And interrupt me at any time if you guys want me to clarify or skip ahead or anything like that. But over 30 years of data kind of supporting the efficacy of this treatment, pain and function scores being the most commonly used measures to kind of compare this to other intervention opportunities. One of our studies called the Summit study looked directly at the Macy in comparison to a microfracture procedure, and both the 2 and 5 year results were very encouraging. Better pain scores, higher function scores with the Macy over microfracture. And that's especially interesting when you consider what each of those procedures are. So Macy, that's the patient's own cells. We're regenerating cartilage, hyaline-like cartilage, so that durable, sustainable cartilage that is going to absorb the most compression, help distribute forces, versus microfracture. And everybody familiar with microfracture, or some of you? What you're doing there is you're drilling into the patient's bone to essentially create like a scab on top of it. You're creating fibrocartilage. And fibrocartilage is less resistant and shows deterioration over time. So especially in like the 18 to 36 month range is when you start to first see that deterioration. So when you're looking at these two graphs, first at 2 years, but then as you look ahead again into the 5 year window, that's where you see the results that you've achieved through microfracture start to decline. Start to have less effect. Just a look at where you might see some of these cartilage defects. So right now Macy is unique to the knee, but where we see them most commonly are in your condyles, patella, and the trochlear ridge. Typically in the ridge you'll also see those a lot of times with the defect on the patella as well. So you can address 2 areas at once in those cases. For any Macy candidate, it is important to understand that any of these underlying factors have to be taken care of as well. And a lot of times those procedures can be done at the same time as the Macy procedure. if you have a meniscus injury, if there's something with the alignment, you have to do an osteotomy to correct that. Those can be done concurrently with the MACI procedure, so the patient has a single intervention, a single rehab to worry about, and ultimately a better outcome. So a lot of these patients are presenting to you guys with other problems, and that's where you identify that there is also a cartilage issue there. Not addressing the cartilage issue while you are already addressing something else can obviously reduce the quality of the outcome that the patient experiences. I wanted to include this quickly because I think this is really important to you guys and the patient. We have a partner company called My Cartilage Care that we work with that does everything from doing the insurance approvals for you guys. So if a patient presents and you take a biopsy, and we'll get into the procedures and the biopsies and all that in just a second, but if there's a potential candidate that presents to you guys and you want to see if this is an option for you, My Cartilage Care can do everything on the insurance approval side. So they can get back to you to let you know exactly whether there's any out-of-pocket cost for the patient. A lot of times there's not. We offer something called copay assist, so if there is a large out-of-pocket for the patient, a lot of times we have some options to cover that. Typically, most facilities never see a bill from us, so the implant, everything is billed through the insurance and doesn't hit your billing department at all, but we can answer all those questions through My Cartilage Care before anything is scheduled with the patient. They're also a resource for the patient. They can educate the patient on what to expect from the procedure. They can put the patient in touch with, we call them mentors, previous patients that have had this procedure done before. They can walk through what the rehab looks like. Really just a really great resource for the patient and for you guys as well. Over 90% approval rates with private payers. So if a patient, their insurance history, and you're questioning whether or not, or who their insurance provider is, and you're questioning whether or not you should take a biopsy because we don't yet know whether or not that's going to be covered, you can be pretty confident with commercial payers that it's going to be covered. And why not take the biopsy while you have the patient there and you're already doing a scope? When you're in there, locations for the biopsy are going to be areas obviously that are non-load bearing, right? You don't want to create a new problem by trying to address the current one. So in the ridge, in the notch, good places to steal a small biopsy from, and it's what we recommend for the biopsy is the size of a Tic Tac. So pretty minimal. Just a quick look at what harvesting the biopsy looks like. You do want to get right down to the subchondral bone. That's where the chondrocytes like to live in the cartilage. And another good recommendation is to leave a piece of the cartilage attached, so you can go in with a grasper and pull that out, and don't risk potentially losing it as a loose body in the patient's knee. All right, so this is what I want to get into next, is just what's in our biopsy kit, what it looks like, what the process of filling out the paperwork and things like that entail. Any questions at the moment? So before I jump into this, a few things that I think are, again, am I blocking that now? Again, relevant to like the why MACI, why have it available, why consider it as a potential option. I was at a sports medicine meeting recently, and well, first they pointed out that cartilage defects on an MRI typically appear, they're underestimated by 50% in size. So you may see something on an MRI, you may not see something on an MRI, right? It could be so minor on the MRI that you just kind of skip right over it, and I've been in scopes where that's been the case, where the doctor did not anticipate finding a cartilage defect. And then the next part was about 60% of arthroscopes, a defect is present. So if a patient is presenting to you guys and they're going through an arthroscope, they're there for a reason. They have some pain, some discomfort, they know of an injury, ligament damage, whatever it is, like, you know there's something going on in that knee. But in 60% of those cases, while you're in there, you identify that there is a defect. So you may have skipped it on the MRI, you may not have noticed it, but you know that there's a pretty good chance that it's there anyways. So for me, what that means is, Dr. Cooper, for example, has 2 biopsies scheduled on Monday. He knows, right? He saw something at some point that indicated he needs to do a biopsy of that patient, but a majority of his scopes as well, he's not going to catch that in advance. So we've been talking about, having these boxes in inventory, having them here for you guys so that once you get into that scope, if it's identified, you have an opportunity to quickly grab a biopsy and store it, get it off to our lab, and then start reviewing the patient's options. You don't need to have all that information answered or figured out prior to taking the biopsy. But these will be here for you guys, so if you're in those cases and a defect is identified, know that you have the tools available. If for whatever reason one of these isn't on the shelf, you can actually still take the biopsy, put it into a saline solution, and I'll get here to take care of the shipment and everything for you guys. But in advance, if we know of the case, I'll be here so that I can help with the paperwork, the shipment, the processing, all that stuff. But if I don't know about it, we can still work together to make sure that that's taken care of. When you open up one of these kits, the first thing you'll see is this. It's a welcome guide for the patient. So this has all the information the patient can need so that they can leave there with answers to some of the questions that are naturally going to arise as they start considering their options and what the heck's going on. There is a QR code on here for them to authorize contact from our My Cartilage Care team. So this is just, hey, somebody can reach out to you and give you more information as long as you go in there and check the box. We also have a form that they can sign and you can fax to us, but the quickest, easiest way is just saying, hey, scan that QR code. It's letting them store your cells, and they will be in contact with you with more information on what you can expect throughout the procedure and process and ultimately the recovery. So everything a patient might want is in the box for them to take home. And then you have instructions on the box as well. So similar to what we were looking at with the collection of the biopsy sample. But most importantly for you guys is going to be the transmittal notice. Let's get the bottle out too. So here's your transmission medium bottle. So your cartilage biopsies are going to go in there. They're going to be sealed up and placed into the bag here. On here is everything you need to include for the patient. As much information, you need to completely fill out this form. Again, if it's a case where I'm here, I'll be doing that alongside you. But ultimately, you want to prepare in advance to read this before the biopsy so you're capturing as much information as possible. Everything from the patient-specific information to whatever you can include about the defect, because that's going to matter with the insurance companies, is the size, location, the impact that the defect is having on that patient. So putting all that information on here is going to help expedite the process through insurance approvals, through cell reproduction at the lab, and getting the patient back for surgery if that is ultimately the route that they choose. But this is simply just packaged up, dropped back in here. There's a couple of, we say room temperature, they're a little cold. Room temperature cold packs. Once this is filled out, there's a label in here as well, so this will all get sent straight to the lab. I guess my biggest message with these is this creates the option, right? It's easy for me to put myself in the patient's shoes. Like if I have knee pain, if I have some discomfort, I don't know what's going on. Maybe I do know, and it's like a ligament damage or something, but that cartilage defect is identified. Like I want that as an option, right? To long-term quality of life outcomes. This preserves that option without you then having to go back for another scope to then collect the biopsy again. So if there is any question of whether or not they are a good candidate for this, you might as well grab the biopsy. We store the cells for 5 years. So one of the things that like we hear all the time from surgeons, whoever, is like, we grab the biopsy and we wait for the patient to return when they're in pain. And like conceptually, that makes a lot of sense. Like, I think a lot of surgeons, a lot of people, rightfully so, probably have kind of the mindset of being as minimally invasive as possible. If they're not going in to correct another issue, maybe it's not urgent to address the cartilage issue, right? Like, let's see how the patient's doing. We do know that the defect is going to continue to progress over time if it's not addressed, but giving the patient that option is important, and having the cells on file for 5 years so that we can start production of a membrane at any time makes it beneficial to have the biopsy done.
How long is the take to create?
We say 6 weeks. We say that to give ourselves a little bit of wiggle room. Realistically, it can be as quick as like 2 weeks. So if you have a patient, and I try to always use like real world scenarios. Patient with a torn ACL. Like, if I had a torn ACL and I'm 18 years old and I want to get back for my senior season, I'm not delaying anything, right? Like, I want to get through rehab, get going. But if I'm 25 and I like tore my ACL skiing, and you identify that there's also a cartilage defect that you can clean up, like, to me, I'm like, yeah, take your time. Let's kill 2 birds with 1 stone. Like, I'm gonna have less knee pain going forward because we waited 4 to 6 weeks to address this. So every patient's unique, patient goals, like all of that, surgeon philosophy, like all of that is going to kind of come into play each time. But the gathering of the cells is step 1. You really can't go anywhere without that. So, any questions on the biopsy kits?
Just a PSA. So we have 2 of the red liquid medium in the fridge, in the OR, and then 2 boxes in my office.
And I think the paperwork is next to the mediums, right? Like in front of the refrigerator? That's what we used to do.
I think they might be in the box.
That way when you grab the medium, you grab the paperwork, since the box can't go in the operating room. So we try to keep the paperwork with the product itself.
Yeah.
And does the patient have to sign a release? Isn't there a patient
So that's
thing?
this. That's the HIPAA file. You can file it, cell storage and HIPAA authorization. It's just kind of making them aware of everything that's happening with their cells. So you can have them sign that and fax that into us, or on the patient packet, you can have them scan the QR code and go ahead and do it on their phone by themselves. Whatever's easier for you guys. Like, sometimes you don't know that you're collecting the sample.
Correct.
And you're not going to go into the patient's room as they're waking up from anesthesia and be like, please sign this.
Well, that's what we used to do.
Yeah,
Because
so
we weren't
yeah.
told ahead of time. We would be taking a sample.
If you know in
based on
advance,
fly.
then great, get the signature out of the way so that you don't have to cross that bridge. But to the point of like, it being hard to detect the defects ahead of time, having this as an option as well is same outcome. To have the biopsy done.
Cooper does. The other guys didn't because it was part of.
I had that case
Yeah.
of Cooper decided to do it in the middle of the case. They had no consent. We didn't have any kids in there. I didn't have any meetings in there, so I had to collect it, put it in saline.
Yeah.
Again, we put it in the refrigerator after collection.
Yep.
Because it's saline
Yep.
as well.
Yeah, never freeze
No, just the fridge.
live cells. Yeah, all the materials from us will have bold letters about don't freeze. You'll kill the live cells. Maybe that's common sense. I don't know. I wasn't a science major.
So do you have to have that release in order to continue the process with the patient?
No.
No.
So we will take in the cells. We will not be able to move forward without, but we will have the cells on file for it. We won't, or my cartilage care partners won't reach out. There will be, it's kind of a dead end for us until we get that, but we will still reserve the option. So if the patient gets back in touch with you guys or the doctor and decides, hey, I want more information or I want to take the next steps, you can do the release then, but ultimately you can take the biopsy, you can send it in, the patient, you know, could be totally in the dark, I guess. I don't know if that's a good way to put it.
Is there a storage fee
No,
for the 5 years?
no. Yeah,
So if we, like Dr. Cooper's got two,
yeah,
let's just say we would bring that out preoperatively to the patient to have them sign that release. And then if he didn't take it for any reason, let's just say this is, you know, far
Yeah.
too large of an area, whatever, they have to do an OATS. We'll just trash the paperwork and you can get us some other one for another medium or
Yeah.
something?
yeah. In an ideal world, you get all these things, all these ducks in a row, and they fall in the perfect order. The reality is like things happen. You get in there for the scope, and plans change, whatever. You know, that's realistic. So we will adapt. We have other solutions, other ways to do it, but and we can always get the authorization down the line if we have to. So I think it's a really good resource. Like back to the myocartilage care piece of it. Patients are something, I'm just like throwing statistics at you guys today. Patients are something like 4 times more likely to proceed to implant if they've been in touch with myocartilage care. So, you know, patients meet with you, they do the biopsy, whatever like information they've gathered, that's like just the tip of the iceberg. Again, like if you're in the patient's shoes, like you're gonna go home and start thinking about this, coming up with more and more questions, rather than them bombarding your phone lines and waiting on callbacks and things like that. My cartilage care is a designated case manager. So for me, I partner with Brianna is her name, and she actually lives in Connecticut. And she's physical therapy background, case manager now with us for like 6 or 7 years, something like that. But she's incredibly knowledgeable. She can walk patients from A to Z. She's talked with thousands of patients, you know, so it's a pretty unique resource that we have that helps the patient make the best solution for them, best decision for them. And like this isn't a solution for every patient. There's still space for OATS and OCA and microfracture for really small focal area. Again, like that all comes down to what the doctor's beliefs are around some of these things, but for the patient where this is the right solution, giving them as much information, as many tools as possible to help them make that decision, I think it is pretty impactful.
I do too, I just don't see anybody doing that for them.
Yeah,
Like
getting
we're not
the
going to
authorization.
Like,
Yeah.
just to even talk to them about what this entails or what they're doing, like they would take it on the fly.
Yeah,
And then it does not go through any of us to go out and say, so the doctor just took this, you know, this is why. Like,
Yeah.
that's not on us, that's on the surgeon to then explain that to them and give them all that information.
Yeah.
I just don't, it's never happened like that.
Yeah.
You know, I don't know if maybe Cassidy in the office would like the number, because if the patient
Sure.
calls and was like, he said he took a biopsy, maybe she could start giving
Yeah.
them that information.
yeah, we could, I
There's
could
so much
connect with Cassidy on that. That's not a bad idea.
Inform these patients
Yeah.
about it, you know, besides the surgeon who will
Yeah.
just say, hey, I took a biopsy, we'll talk about it.
I
Okay.
don't think they talk about it in the post-op.
I think maybe in the post, but that's what I mean, they're gone from here, so maybe
They're
it's
gone
the
for a week or
office
a week
should
and
be
a half, yeah.
an area. I think here they just say, hey, we took a biopsy,
Oh,
you
yeah,
know,
yeah.
whatever, I
But-
don't think they go into it.
Is it okay? Like, what is the issue if they just go to the office and they're like, okay, this is a procedure?
No, it's good, but I
Okay.
think that's what, the office should have this information, like that
Yeah.
You
care
did
card
go to
and
the
stuff.
office last week, right?
Yeah. I'll circle back with Cassidy. That's a really good idea. I think like partnering with us looks different for everybody's workflow. So like we can figure out how that best fits in with you guys. You know, our solution is relatively small volume. It's a really small piece of the pie in terms of what you guys do. So I just think that makes it all the more important for us to be as easy and as flexible as possible for you guys to, you know, kind of have the resources available, have the information, let us run with it from there. But yeah, we can kind of tailor that to what it looks like on your end. I'll spare you all the boring science behind it. Our cells go, they get in a 2D dish, it ends up on the membrane, it resorbs back to a 3D scaffold-like structure, and it comes back to you, but it's still just a very, very thin membrane. And that is where a surgery day comes in. I think I have a picture of our kit coming up. Yes, all right, so day of surgery, we are one instrument tray. It's a very simple procedure. It's a mini arthrotomy. You know, it's a small incision that you need typically to access depending on where the defect is. It can be done at the same time as other procedures. I've seen it done with MPFL reconstructions, HTOs, TTOs. It's a very simple part of the process for very talented surgeons, obviously. But this is it. These are all the instruments that you need from us. Now, if you're opening up a knee, you're going to need your typical knee trays, but this is what comes for us. So over here, these are the cutting instruments. They are used to match the defect to the implant that is going in. When the implant comes, it's a 3x5 rectangle. You're going to cut it to match the defect. So one of these instruments will totally outline the defect to give you nothing but big shape surrounded by healthy cartilage. Then you're going to go back to the instrument, into the implant, and cut the implant to match that shape. So it's going to fit like a perfect puzzle piece. And we have ring curettes to kind of just scrape out that affected cartilage. So when you do get to, I should stop switching sides.
You're fine.
So yeah, you're gonna end up with a look like this when you mark out the defect with the first cutting instrument. You're gonna go with the ring curettes. Oh, this is cool. No, that's as far as it goes, I guess. All right. You're gonna go with the ring curettes to clear out the rest of the space. Place the membrane itself onto the cutting block, where you'll use the mallet to. I keep thinking they're going to show another part of that. You're going to use the mallet to hammer the cutting instrument onto the. But you'll prep the defect. It's very plugging in a matching piece to the area that you've prepped. But it's very simple. The implant itself is secured with a fiber and glue. We most commonly see centers used to seal. I don't know if you guys are familiar with that material, but it's derived from human blood cells, so it's very biocompatible glue. Takes about 3 minutes to dry to adhere. It's a quick, easy procedure, and I think in the scope of things, but single instrument tray. A lot of times you'll see these procedures done in a half hour, 45 minutes. There's the prepped defect bed. All right, we're a little bit out of order, but. And then I guess like the recovery phase. Depending on the severity of the defects, if there's multiple defects in the location, recovery looks different for each patient, but generally speaking, they are back to range of motion, full range of motion within 3 to 6 weeks. They are back to daily activities within 3 to 6 months. Things like cycling, typically around the 3 to 6 month window. So rehab is very specific to each patient and where their defects are located. And the physical therapist will kind of come up with a plan that is tailored to how they're responding to each step. But the recovery period can be anywhere from ultimately 9 to 12 months. And we have a ton of resources on that too.
How long is the re-implanted cartilage lasting for?
How long does it last for? So it is hyaline, we say hyaline-like, but it's the patient's own cells. So it's cell-based restoration as opposed to taking a graft from somebody else or taking a graft from the patient's existing cells and potentially opening up. So it is more durable than the alternatives. We are seeing that in positive cases, those patients never return with pain or other symptoms. I think one of the cool ways that helped me think about it was somebody said, we may not prevent the knee replacement, but we may prevent a total knee revision, meaning if your patient is 30 years old and you're able to intervene now and buy them 20 years of pain-free knee. And then at 50, 55, they do a total knee. That total knee might now last them the rest of their lives, while doing a total knee at 35 likely came with a revision, multiple revisions down the line. So it's a less invasive intervention now that could prevent greater problems down the road. May still lead to further corrections 20, 25 years down the road from now, but even still it could be a much more effective process for them.
Is there an age limit to?
Yes, we are indicated ages 18 to 55. Doctors have made decisions to treat patients outside of that age range, but cells are typically more active in younger patients, so over the age of 55, it's not always the ideal candidate. Also, when you get over the age of 55, a lot of times the defects have progressed beyond repair, right? We don't treat osteoarthritis. If you think of like osteoarthritis as like a crumbling road, that's not really what we treat. We're more of like plugging potholes. So over that age, we don't typically treat. It's more common that we see doctors choose to treat under that age and the right fit for a teenage patient. But that's.
They ever migrate and become loose bodies?
Not that I'm aware of. The other thing that I think makes this an ideal like first treatment for a lot of patients is our treatment doesn't violate subchondral bone. So other treatments, you have to either penetrate or remove the bone. This doesn't do that. When you do that, you can reduce the number of options that are available to you down the road if you do have to do a revision surgery, by damaging the bone. So.
Once the patient has a return surgery date here, you guys will ship it to us,
Mhm.
and it has to stay in the refrigerator, or is it a refrigerated item at that point?
Yeah, timelines, that's a really good question. Timelines are important. So biopsies are good. They have to return to our lab within 72 hours. So as soon as they are taken, I will be coordinating to have it picked up and transmitted to our lab. Our lab's in Burlington, Mass, so it's not too far away, but it has to get to our lab and into our facility within 72 hours. On the other end, when we ship, when the implant leaves our facility, it is good for 3 days. So we are coordinating with you guys throughout the process. Like, we don't start growing the cells until we have a selected surgery date. And everything has been agreed to leading up until that. For implants that are on Monday or Tuesday, the implant typically arrives morning of. For Wednesday, Thursday, Friday, it typically arrives a day before. So again, like, that's things that we need to coordinate. My cartilage care patient coordinator will be involved in that process with you guys to make sure, like, if you have a 7:30 a.m. surgery time, like, arriving morning of isn't really an ideal way to schedule it. So we need to be, kind of considerate of all of that when we're setting things up. So.
And that tray will come in a few days before, so we can sterilize it.
Yeah. Yeah, that'll typically be me dropping that off. So.
Like I said, 13 years, I've never done an implant, ever.
I think
Yeah.
I think I did the one that we did here.
Yeah.
But there was a reason why we couldn't do them here, and I can't remember.
That's
what
what
it
I
is. Is it
don't remember.
reimbursable? The
So,
reimplantation?
I mean, typically that's not the issue. In a vast majority of cases, the facility never sees a bill from us.
We have a lot
So,
of Medicare and Medicaid patients, like 60%
Medicare and
are
Medicaid,
payers.
I'll actually have to clarify in Massachusetts what that looks like, but typically those can be more challenging, but like workers' comp, private payers, those have very, very high approval rates.
We just-
Yeah, and it's a really highly, like, not that that's important when it comes to like making the best decision for the patients, but it's a very highly reimbursed procedure, so.
Has Cooper reimplanted any that he's collected this far?
I think he did 2 last year. So,
Reimplantations, I've read that.
Yeah, so, yeah.
I don't know if this was asked because I came in late. How long does it take to grow the breath once you grow?
4 to 6 weeks, I said 2 to 6, but like realistically, yeah, give yourself a little wiggle room. But.
Once we have the biopsy and we put it in the box to send back to you, other than the paperwork that goes in, everything else is all set, do we need to call you to tell you it's on its
Yes,
way? or-
I'm gonna leave you guys with this, cause this is like laminated, dummy proof, there's a little hook so it can hang somewhere. But those are all the steps for the biopsy, and the return. But you will call one of the important things, this sheet is everything that needs to get done. There is a little label on here that you include patient identifiers on to go onto the bottle. Because when this gets back to our lab, if that is missing or if any patient identifiers are missing, like that biopsy gets thrown out and discarded, and the patient has no cells on file with us. So it's really important that that identifier gets on here, it's on the labels going on the box, and everything is consistent. Same thing like when it comes back to us, like there's 2 or 3 places that we need to check to verify that the cells that we are about to implant into the patient match everything along the way, so.
We have to include a face sheet as well.
Yes.
This information.
Yeah.
When you grow the cell and you ship it in because you know they're having surgery, that surgery gets canceled. So now the graft is no good. Do you save cells, or when you grow one?
Yeah, cells will still stay on file for 5 years, as long as we have enough, so that's a good question. Not every biopsy they're not all created equal. Not everyone contains the same amount of cells, so that's why we ask for typically 2 200 milligram samples of cartilage, so that it's predictable that there will be enough cells in there for us to produce an implant out of it. In some cases, there will be multiple defects or defects big enough that we need 2 membranes. If we don't have enough cells, we're not gonna be able to produce 2 membranes. So, yeah.
So with a collection, how many membranes would
With a selection, that's not a question for me, unfortunately, that I can feel confident answering, but if I were to just create a wild guess, I would guess like 2 to 3 membranes.
Is there a maximum size of the defect that Macy can cover?
It is greater than 10 square centimeters, I believe, is what we kind of mark as the high end. But it can be defects with or without bony involvement. So a lot of times when there is damage to the bone as well, you kind of jump to think like, oh, that's no longer a Macy treatable patient, and it is. And there's even some techniques for some bigger bone defects where we can treat those as well. I say we, you guys are doing that. I'm not doing it. Questions?
I have another question. So say
Yeah.
we plan it, we get it, the case gets canceled, who discards it? Does that go back to you, or we just throw it out?
I assume if it's here, you're going to be discarding of it, but yeah, there's kind of like a protocol and steps along the way where we're agreeing like, all right, we're starting production today for implant date X, and it would be a unique scenario that we shipped it and didn't have like confirmation from you guys, so.
No, we had a similar issue where the patient canceled at the last minute, and we
Really?
had.
Yeah. Yeah.
And then it was only good, the fresh graft was only good for like 4 days, and.
Yeah, that's gotta be the case.
They
3-day,
canceled.
3-day shelf life on our graphs.
Yeah.
Yeah.
And they canceled, so it was just trash to us, we got rid of it, we didn't call it back. So
Yeah.
We were just wondering if that's what we would do with you too.
Yeah, I would
Patient
assume so.
cancels,
I would
we're
assume
gonna
so,
cover
right?
yourself.
Like we can't control every variable that goes into it, but yeah, we'll figure that one out. I have some extra resources up here, just with example cases. This is a good one for going over cases with patients because it just kind of gives you an idea of what to expect, like what that graph looks like when it goes in versus where you can expect 12 months from now, and the type of equipment and conditions that you can experience. Surgical manual encompasses everything from biopsy to surgery. We are also approved, we have separate instruments for arthroscopic delivery. That's another day if any of your surgeons decide that they want to go that route. And we have a rehab manual as well. I'll leave both of those with you guys. The rehab manual is cool. It's like very specific to the type of defect that the patient might experience and the steps that they're gonna take along the way where they can expect to be. If you have a blue collar employee that wants to know when they're gonna be able to get back to work based on what you know about their defects, you can kind of walk them through the process and what that might look like. If you have an athlete that just wants to get back on the field, like, same thing.
Thank you.
All right, thank you guys.